So today's class will be on the meningitis. See, one of the important topics in internal medicine. Even today we see a lot of the cases in the casualty with the fever, vomitings, photophobia, altered sensorium, nausea, vomitings, and if you examine the patient, maybe neck rigidity, etc., and definitely your provisional diagnosis could be a meningitis. So thus meningitis is a very important disease, and you have the several subsets of the meningitis like viral meningitis, bacterial meningitis, tuberculous meningitis, fungal meningitis, or oncology meningitis, or immunosuppressive meningitis, etc. See, these are the layers of the brain. So the meningitis means infection of the layers of the brain. So we have the dura mater, arachnoid matter, and the pia mater. And usually the meningitis is the inflammation of the arachnoid and the pia matters. And you will have the subarachnoid space. So in that filled with the cerebrospinal fluid. So that will be the infected, and sometimes there may be the purulent CSF will be there in the subarachnoid space. So this is the combination of the pyrexia, headache, meningism. Occurs in the other situations like subarachnoid hemorrhage also, but there no fever. But here fever will be there in the meningitis. So you will have the two important signs, Kernig sign and the Babinski sign. So what do you mean by the Kernig sign? When the hip joint is flexed, extension of the knee causes spasm in the hamstring muscles. So that is the Kernig sign. Whereas the Brudzinski's, the passive flexion of the neck causes flexion of the thighs and the knees. So the flexion of the hip joint and the flexion of your knee joints will be there in the Brudzinski's sign. So both will be positive most of the times in the presence of severe meningitis. So this is the Kernick's and the Brudzinski's. So in the causes, you have the different bacterial, and coming to the viral, it's a very common is the enteroviruses, herpes simplex, Epstein-Barr, influenza, mumps, zoster, HIV, and others. So these are the important viruses in our setup to cause the viral meningitis. And sometimes the protozoa and the parasites, especially the cerebral malaria, is a very common in our area. It almost looks like your meningitis. So toxoplasma is the most important meningitis occurs in the HIV individuals, and the ring lesions, cystic lesions is a very common, coin lesions, etc. And amoeba, so central nervous system amoebiasis is also common. Cysticercosis, that is neurocysticercosis, ring lesions again in the brain parenchyma. In the fungi, so the different fungi will be there. It is a very common in the HIV individuals, very common in the chronic diabetics, common in the people who are on medical oncology cases, and is very common in alcoholics and other immunosuppressive drugs. Those people who are in chronic steroid therapy and the fungal infections are very common. So the Cryptococcus, Candida, Histoplasma, Blastomycosis, Coccidiosis, and Sporothrix. So these are also very important. The sterile meningitis. So how many times you do the CSF examination, LP, and always it's the negative. Gram-Stein will be the negative, culturing sensitive will be the negative. Then you consider this is the sterile meningitis. It could be because of the malignant diseases. Most common is the breast cancer, bronchogenic carcinoma, leukemias, and the lymphomas. And inflammatory diseases, it may be the recurrent meningitis. Meningitis occurs several times with the different organisms, or sometimes with the same organisms if it is occurs more than the 3 weeks of the complete recovery. That is the definition of your recurrent meningitis. So the recurrent meningitis could be because of the recurrent bacterial meningitis or recurrent meningitis due to these inflammatory conditions like lupus, sarcoidosis, and others. Lupus and sarcoidosis are very common in our setup. So you should not forget these recurrent meningitis as a DD for this lupus and the sarcoidosis. See, once you suspect the meningitis, and usually we have to diagnose it with the CSF examination. So LP will be done between your L3 and L4 vertebra, and you know how to do the LP. It should be done under complete aseptic precautions. And then after seeing the cerebrospinal fluid, you can come to a reasonable diagnosis that it could be viral meningitis or bacterial meningitis or fungal meningitis or Cox meningitis. So usually normal, the cells are most of the lymphocytes. The cell count is very minimal, and the glucose is more than 60% of the blood glucose that is the normal CSF contains. In the viral meningitis, the cells, most of the lymphocytes, maybe to the tune of about 50 to 70%, and 10 to 2000 cells, glucose will be the normal in viral meningitis, and the protein also will be the normal. And our interest is today's topic will be on the bacterial meningitis. Here, the cells are more of the polymorphs, nearly to the tune of about 80 to 90%, but usually it is a lymphocytes, but here dominated by the polymorphs. And the cell count will be 1000 to the 5000s. Glucose will be the low to the tune of about less than the 40 milligrams. Or in an uncontrolled diabetic individuals, you should maintain the ratio, you should get the ratio of your CSF glucose versus the blood glucose. It should be less than 0.4. Protein in bacterial meningitis usually elevated, maybe more than the 4.5 grams. And gram stains will be the positive in about 60 to 70% of the cases. So immediately we have to send the CSF for the gram stain also, because to select the appropriate empirical management for your antibiotic therapy. Because we have to start the antibiotics very fast in the presence of the meningitis. Otherwise, it is going to be a big killer. Even today, about 10 to 20% of the cases of the meningitis, they die because of the improper selection of the antibiotics or a delayed initiation of the antibiotic therapy in the presence of the bacterial meningitis. So in the Cox, you will have the polymorphs or the lymphocytes, mostly the lymphocytes, or a combination of the polymorphs and the lymphocytes. Cells to the tune of about 50 to 5000. Glucose will be the low and protein will be elevated in Cox meningitis. And gram stain usually the negative, unless it is associated with the mixed infections like a mixed bacterial, then you may be the positive. You can get the gram stain positive or negative also. In fungal, it is the lymphocytes. Cells are very low, 50 to 500. Glucose will be low and protein will be elevated. So this is how you have to see with your CSF report whether it is a viral meningitis or bacterial meningitis or Cox meningitis or the fungal meningitis. So the gram stain will be the positive in about 60 to 70% of the cases in bacterial meningitis. The protein will be elevated in bacterial meningitis and tuberculous meningitis and also in the fungal meningitis. But more elevation will be seen in the bacterial meningitis and the Cox meningitis. And if you see the cells in the bacterial meningitis, mostly the polymorphs, whereas in the tuberculosis and the fungal, it is more of the lymphocytes. And the cell count will be the very high in the bacterial meningitis, whereas it will be somewhere between 50 to 5000, maybe 50 to 2000 in Cox and 50 to 500 in fungal meningitis. So this is how you have to differentiate according to your CSF examination between these three things: viral, bacterial, and Cox. Few slides about the viral meningitis before we move on to the bacterial meningitis. It is the most common cause. Even in the children, I think this is a very, very important cause. Like your herpes simplex virus, influenza virus, or mumps virus, etc. Whereas in an adult individuals, maybe the HIV is a very important cause here. Benign and self-limiting, requiring no specific therapy. But in the viral meningitis, we definitely have to use the acyclovir intravenously, provided if it is a viral meningitis. Less serious illness than the bacterial meningitis unless there is an associated encephalitis. If the brain parenchyma is involved, then we consider it as an encephalitis. But unfortunately, most of the viral diseases, viral meningitis, it also involves the brain parenchyma. So your term will be the meningoencephalitis rather than the meningitis alone. The causes, the most common here is the ecovirus, where specific immunization is not employed, mumps virus. See, because of the good immunization about these three viruses. One is the influenza virus, you have the vaccination, and meningococcal is the bacterial, you have the vaccine, and the pneumococcal, you have the vaccine. So these three vaccines are must for all the children and also the young adults who are more prone to get the meningitis. Viral is mainly in the children and the young adults, acute onset of headache, irritability, and rapid development of the meningism. That is our neck stiffness, etc. So irritability, it varies from the person to the person. So sometimes there may be a brief loss of the consciousness or the deep loss of the consciousness. Sometimes the fellow may be in the deep coma also. So the more the loss of the consciousness, that is the disease is very, very severe. Headache is the more severe in viral meningitis, a diffuse headache all over the skull, high grade fever, and focal neurological signs are rare in viral meningitis when compared to the bacterial meningitis. Or in bacterial meningitis, or in tuberculous meningitis, or in a fungal meningitis, you might see some of the focal neurological signs there. Maybe the focal convulsions or generalized convulsions, etc. But here in viral meningitis, mostly the fever, headache, and sometimes the nausea and vomitings. CSF in viral contains an excess of the lymphocytes. Glucose in the protein levels are usually normal, or the protein level may be elevated. It is not that high when compared to your Cox meningitis or bacterial meningitis. Patient has not received the antibiotics prior to the lumbar puncture. Yet this picture can also be found in partially treated bacterial meningitis. See, unfortunately, most of the people, by the time they reach our hospitals, they might have taken a few antibiotic shots from the RMPs and etc. So that will give you a false impression that whether it is a case of the true viral meningitis or a bacterial meningitis. No specific treatment, usually benign and the self-limiting, are treated symptomatically in a quiet environment. Recovery usually occurs within the days, and lymphocytic phagocytosis may persist in the CSF. Meningitis may also occur as a complication of a viral infection primarily involving the other organs. Example, the mumps, measles, infectious mononucleosis, herpes zoster, and viral hepatitis. So some of these cases may present like a viral meningitis also. So complete recovery without the specific therapy is the rule, but you have to see, you have to know that it is only the viral meningitis. Otherwise, if it is a bacterial meningitis or a fungal meningitis, if you don't involve with a proper antibiotic or antifungal, so definitely these people will end up with the focal neurological signs, and these people will develop with the brain edema, hydrocephalus, herniation, and then finally death also. So it is our duty to see this meningitis is always because of the viral or bacterial or fungal or Cox. So then only the treatment varies, and if luckily if there happens to be a viral meningitis, and recovery is the rule. HIV and HIV, already I discussed a few weeks ago, entire HIV. Seriously ill patients should probably receive the IV acyclovir. In less severely ill patients, oral acyclovir or famciclovir. IV immunoglobulins, not in all population. Patients with viral meningitis who are known to have the deficient humoral immunity, maybe the complement deficiency or humoral immunity deficiency, definitely they need immunoglobulins. Now move on to the bacterial meningitis. It's a very, very common and left untreated, a lethal disease. Many bacteria can cause meningitis. Most common is the pneumococcal pneumonia. So that's the same bacteria which causes your pneumonia that also cause the meningitis. And in the Western countries earlier it was the H influenza. So that also was the common cause to cause meningitis. Now with the introduction of the vaccines, the incidence of the influenza meningitis has reduced drastically. Certain organisms are particularly common at the different age groups. So if you are seeing a case of the neonates, maybe the listeria is the most common cause. And if you see the elderly individuals, hospitalized individuals, those people who are in the ICUs, or with the pneumonias, etc., maybe your Staphylococcus aureus may be the important cause. So the organisms varies, common organism varies from the age and also the time of the admissions. Bacterial meningitis is usually secondary to a bacteremic illness. Infection may result from the direct spread from a distant focus of the infection. Maybe the anatomical defects in the skull, or maybe the fractures, or maybe because of the chronic sinusitis, or chronic otitis media, or chronic mastoiditis. So these are the very, very nearer area to your meninges or to the brain, like your nose, ear, etc., or orbital cellulitis. So there is entry of the organisms very easily into the meninges by crossing your blood-brain barrier, and definitely they cause a lot of the infections in the subarachnoid space. And once the bacteria enters into the subarachnoid space, they multiply like anything, and then definitely they cause a purulent CSF and then the bacterial meningitis. So these are the very, very important. So those people with a chronic sinusitis, a chronic otitis media, or chronic mastoiditis, they have to be addressed very aggressively, not only with your medical management, sometimes maybe with your surgical management. Otherwise, these people are the potential candidates to get the meningitis. So again, as I told you earlier, recurrent meningitis, that is also very common in these situations. So in such individuals, definitely we have to treat aggressively. Bacterial meningitis is less common in the West, not that less common in India. Here still very common. Mortality and the morbidities are very, very significant despite the availability of an increasing range of the antibiotics. See, nowadays we see a lot of the antibiotics in our hand. So you have the ampicillin, you have the aminoglycosides, you have the cephalosporins. Different cephalosporins are there in our hand, like ceftriaxone, cefixime, ceftazidime, cefoperazone, etc. And also you have the meropenem or ibupenem like carbapenems, and you have the lizolids, a gram-positive specialist, and also we have the vancomycin, and also other antibiotics are there in our hands. Still, in spite of that availability of the many antibiotics, but still the morbidity and the mortality of the meningitis is very, very high just because of your drug resistance. So the drug resistance is a big problem, especially in India. That is the reason even today, so a lot of these bacteria are resistant to your ceftriaxone. So that is the reason we are not happy with the ceftriaxone alone or your ceftazidime, and we add the vancomycin also in the management of the meningitis. In the same way, if you see the listeria, and we add the ampicillin also. And some people who are resistant to these drugs are hypersensitive to the penicillin group of the drugs, we have to go for the chloramphenicol IV. So these are the important antibiotics. In spite of that, still I worry about the diagnosis of the meningitis, because 10 to 15% of these meningitis in my hand, they are going to collapse. The main important reason is late entry into the hospitals. Late entry into our hospitalization. By the time the patient is so sick, by the time the patient consciousness is very, very low, very impaired, and already the patient is having the focal neurological symptoms, already had an history of 1 or 2 fits, convulsions. So these are the people who are going to die because of the diffuse cerebral edema, because of the increased hydrocephalus, or because of the increased intracranial pressure, and because of the early herniation. So definitely we are losing these patients. So the take-home message is bacterial meningitis, we have to treat very aggressively, and you have to diagnose as early as possible, and you have to go for the LP and the CSF examination also as early as possible. And if you want to start the antibiotics here, adjuvant therapy like steroid therapy is also important. So you have to give one steroid maybe 15 to 20 minutes before the antibiotics or along with the antibiotics to avoid the inflammation, further inflammation or granulation, and to have the good recovery. See what is the importance of the steroid to be given before the antibiotics. I will tell you at that time. The important factors determining the prognosis is the early diagnosis and prompt initiation of the appropriate therapy. In India, Haemophilus influenza B and Streptococcus pneumoniae are the most common causes, at least in the children, even in the adults. Even in our physicians' practice, these two are very important. So now, number 1 is the pneumococcus, that is our Streptococcus pneumoniae, pneumococcal meningitis, and number 2 is your meningococcal meningitis. Okay, and then it will be the influenza, that's it. Streptococcus pneumoniae is the most common in the Western Europe. Meningococcus is the second, and USA Haemophilus influenza. Meningococcus and other common causes of the meningitis normal commensals of the upper respiratory tract. See, these bacteria are there in the upper respiratory tract. So in the nasopharynx. So in the nasopharynx, they secrete IgA proteinase enzymes. So that will destroy your mucosal barrier. And then they keep these bacteria to enter into the brain tissue. So once they enter into the brain tissue, so definitely they cause a lot of the infections. So new and potentially pathogenic strains are acquired, airborne route and close contact. So if you see the meningococcal meningitis, it is through the airborne. And the pneumococcal pneumonia, so maybe the patient may had a pneumonia and then it may be hematogenous spread to the brain. Epidemics of meningococcal meningitis occur particularly in the cramped living conditions in the rural India, hot and dry climate, organism, not only in the Africa, even in our India also we have the hot and dry climate. Organisms invade through the nasopharynx, already told you, and producing the septicemia can lead to the pyogenic meningitis. Chronic meningococcemia is a rare condition. A patient can be unwell for weeks or even months with a recurrent fever, sweating, joint pains, and the rash. See, rash is very common in meningococcal meningitis. Even though the book says that 60 to 70% of these people will have the rash over the extremities, but to be frank, I seen only the 10 to 15% of my meningococcal meningitis people had the rash. So rash is not that common in our Indian population when compared to the Western population. It usually occurs in the middle-aged and the elderly individuals and previous splenectomy. Yes, you know that asplenia, more cases of the pneumococcal pneumonia, and multiple myeloma, complement deficiency, hypogammaglobulinemia, lymphomas, leukemias. So these are the conditions where the chances of having the pneumococcal pneumonia, meningitis is a very common situation. So that is the reason these people should be given a pneumococcal vaccine. See, these are the causes of the meningitis. You concentrate on the Walter chain on the adults. This is our specialty. Here the Streptococcus pneumoniae and Neisseria meningitidis, that is your meningococcal meningitis. Less common is the Listeria. The Listeria is more common in the neonates and also common in the elderly individuals. Here the drug of choice is the ampicillin. Mycobacterium tuberculosis is very, very common all individuals from neonates to the geriatrics. Skull fractures. See, I told you the skull fractures, neurosurgical procedures or post-neurosurgical interventions, etc. So there's a high chances of entry of the bacteria into the brain causing the meningitis. Complications of these septicemias, so meningitis. So that is the reason whenever I say malaria, whenever I talk about the typhoid, whenever I talk about the other diseases, pneumonias, etc. So there are all chances of having the meningitis because of the hematogenous spread. Shock is very common in meningitis. When the fellow is presenting with a shock and the casualty, and the mortality and morbidity will be very high. So the initial presentation is very important, whether the patient is alert or deep coma. Deep coma, more mortality. Alert, good recovery. Intravascular coagulation. So the DIC is also very common with the meningococcal meningitis. Renal failure, acute kidney injury is very common in all the types of the meningitis when they present at the later stage. And peripheral gangrene, arthritis, pericarditis. So these are the very, very common. See, the pericarditis, endocarditis, pneumonia, and then meningitis. So these three, a combination will be there. That is the pneumococcal pneumonia causing pneumonia. Pneumococcal pneumonia bacteria will causing the endocarditis, and then the meningitis. And you name one syndrome here. That syndrome name is Austin syndrome. So Austin syndrome means pneumococcal pneumonia plus endocarditis plus meningitis. That is Austin syndrome. Otitis media in the pneumococcal, Haemophilus infections, Pneumococcal meningitis may be associated with the pneumonia, occurs especially in the older patients and the alcoholics following the splenectomy. Listeria emerged as an increasing cause of meningitis and probencephalitis, that is the brainstem encephalitis, in immunosuppressed, diabetes, alcoholics, pregnant women. See, pregnancy and meningitis is a very, very big problem. So one should be very careful about the fever, vomitings, altered sense in the pregnant individuals. Can also cause the meningitis in the neonatal period. See, the meningitis is a very common disease from the neonates to the geriatrics population. So pregnancy is also part and part of your adulthood and the adolescence. See the pathology, see the pus there. So there are the 6 stages in the pathogenesis of the bacterial meningitis. One is the colonization of the nasopharyngeal epithelium. So it was not written here. Stage 1 is a colonization, normal colonization. Stage 2, so the epithelial cell invasion. And stage 3, invasion of the meningeal vessels. And the 4th, intravascular multiplication and the bacteremia. And the 5th, crossing the blood-brain barrier, bacterial entry into the cerebrospinal fluid. And then the survival and multiplication in the CSF. So these are the 6 stages of the pathogenesis of your bacterial meningitis. So the colonization of the nasopharyngeal epithelium, and then the epithelial invasion, then invasion of the vessels, then intravascular multiplication and bacteremia, and crossing the blood-brain barrier, and finally multiplication in the CSF leading to the meningitis. So this is all the 6 stages of the bacterial meningitis as far as the pathology is concerned. See, as I told you that the pia and arachnoid is congested and infiltrated with inflammatory cells. That inflammatory cells depends upon your type of the meningitis. That inflammatory cells are more of the polymorphs, which is the bacterial meningitis. Lymphocytes is the cox and fungal meningitis. Usually the cox is a chronic meningitis, not an acute meningitis. When you are considering the acute meningitis, mostly the viral meningitis or the bacterial meningitis. When you are talking about the chronic meningitis, it could be cox or the fungal. So the thin layer of the pus forms, and this may later organize to form the adhesions, may cause obstruction to the free flow of the CSF leading to the hydrocephalus. You all know that CSF starts from your lateral ventricles. From the lateral ventricle, it entered into the third ventricle. From the third ventricle, it entered into the fourth ventricle. And then the fourth ventricle to the subarachnoid space and entire brain. So if any obstruction is there, then it will cause hydrocephalus. And then it will be increased intracranial pressure. And there will be the herniation into your herniation. So these are all very, very bad signs. So the diffuse cerebral edema or hydrocephalus or increased intracranial pressure. So these are the very dangerous. So while doing your LP and while the CSF is, you are collecting the CSF, we can definitely say whether the CSF is the normal pressure or abnormal pressure. When the flow is very fast, when the drops you are getting is very fast, so there is a risk of increased intracranial pressure. That is the reason before the LP, one should get the neuroimaging, either the CT or the MRI. This is very, very important. So otherwise, when the fellow is in the increased intracranial pressure and hydrocephalus, and if you perform the LP, the chances of herniation is very high and the death is very, very sure. So that is the reason. So LP, when the patient is awake, is not drowsy, and no history of convulsions and etc. So definitely without the neuroimaging also you can go for the LP. And otherwise, if the patient is deeply comatose and had a history of convulsions etc., so always better to get a neuroimaging before you do the LP. CSF pressure rises rapidly, protein content increases, cellular reaction varies in the type and the severity. Already told you the cells, according to the nature of the inflammation and the causative organism. Endarteritis may produce the secondary cerebral infarction. This is also there as a one complication of the meningitis. You will have the cerebral arterial thrombosis, cerebral venous thrombosis. All these times I told you this diffuse cerebral edema, hydrocephalus, increased intracranial pressure, or coning, etc. But these two are so very important. Cerebral arterial thrombosis and cerebral venous thrombosis. These two are very common complications of the untreated and severe bacterial meningitis. Pneumococcal meningitis is often associated with a very purulent CSF, high mortality, especially in the older adults. So all in the older adults, so the mortality will be very high because they present with the mixed organisms. And then already they are known diabetes, hypertensives, or IHD, or CKD, etc. So the immunity also at a lower level. So definitely the older adults, if they get maybe more than the 80 years of age group, etc. And if you diagnose them as the bacterial meningitis, so the chances of survival are very, very low. See the here. So the brain tissue filled with the pus. So the clinical features, again, it is not always pertaining to your brain. So maybe the generalized symptoms will be there. So headache will be central, altered mental status. Ears, there will be the phonophobia or photophobia. So they can't open the eyes in the open bright light. So they always closes the eyes. So that is the photophobia. So they want the dim light. And the phonophobia. So neck stiffness, already told you, neck stiffness is not always meningitis. In the elderly individuals, maybe severe cervical spondylosis, so there may be the neck stiffness. Maybe the cervical spine lesions, there may be the neck stiffness. But here in meningitis, you will have the vomitings, you will have the fever, and you have the headache, etc. So the neck stiffness is in alone is not meningitis. And then the trunk, mucous membranes, etc. See the rash here. So that is there. If you see the books, about 50 to 60% of the meningococcal meningitis, but in practicality, maybe the 10 to 15% of the individuals. Usual presenting features: headache, drowsiness, fever, neck stiffness. All these four will be present in only less than 40% of the individuals. Any two will be present in more than 80% of the cases of the bacterial meningitis. Okay. So in severe bacterial meningitis, and later there may be the focal neurological signs. Meningococcal meningitis associated with a purpuric rash in 70% of the cases, accompanied by the septicemia, present rapidly with the abrupt onset of the pigmentation due to the cerebral edema, a result of endotoxin under cytokine release, and circulatory collapse. See the child. Maybe because of the meningococcal meningitis, the rash and etc. Seizures, 20 to 40% of the patients. Initial presentation or during the course. Focal seizures due to the focal arterial ischemia or the infarction, already told you. So there will be the cerebral arterial thrombosis or the cerebral venous thrombosis. Cortical venous thrombosis, the hemorrhage or the focal edema. So all these things can be seen in your MRI brain. So the MRI is always useful in meningitis to rule out all these complications. So what are all the complications? You will have the diffuse cerebral edema can be detected, and the rise intracranial tension will be detected, and you will have the ventriculitis will be detected, and the false cerebral sign will be seen, and then there will be the coning will be seen, and there will be the cerebral arterial thrombosis, cerebral venous thrombosis can be seen. So all these complications can be seen in your MRI, and then you can act accordingly. Generalized seizure activity and the status epilepticus can also occur due to hyponatremia, cerebral anoxia, and toxic effects of your antimicrobiological such as high dose penicillins. So these are all. So hyponatremia, cerebral anoxia, and the toxic effects of your antibiotics. So the electrolytes is very, very important in the management of meningitis. So some of the people may develop the seizures in hyponatremia. Raised ICP, expected complication of the bacterial meningitis. Major cause of obtundation and the coma. More than 90% of the patients will have a CSF opening pressure of 180 millimeters of mercury. So not mercury here, water. We say in the CSF millimeters of water rather than the millimeters of mercury. Millimeters of mercury in our blood pressure. Okay, here it is the water. And 20% have the opening pressures of 400 millimeters of the water. What is the normal CSF pressure? 50 to 180. So 50 to 180 millimeters of the water is the normal pressure. Usually in the meningitis it will be more than 180. Sometimes maybe the more than 400 also. Okay. What is the average volume of the CSF in the brain? 150 ml. 150. What is the average production of the CSF per day? 400 ml per day. But it is only 150. So remaining 250 will be absorbed into the circulation. Okay. So the average production is 400 ml. Exact presence is only 150 ml. And remaining 250 will be absorbed into the circulation. So these are the signs of the increased intracranial pressure, deteriorating at the reduced level of the consciousness, papilledema. So the fundus examination is always needed in all the meningitis patients. Dilated or poorly reactive pupils. The pupils will be dilated and not reactive. So again, it is an ICP, increases ICP. Sixth nerve palsy. Usually in the meningitis, what is the cranial or most common cranial nerve involved in meningitis? Not sixth. Not sixth. Most common cranial nerve involved in the meningitis, bacterial meningitis. 6 plus 2. 6 plus 2. Eighth cranial nerve. Eighth cranial nerve is the most common cranial nerve involved in the bacterial meningitis. So the hearing loss is very common in bacterial meningitis. Maybe 15 to 20% of the people they lose hearing. But in raised intracranial pressure, it is a sixth cranial nerve palsy. Decerebrate posturing. Cushing's reflex. What you mean by Cushing's reflex? So bradycardia, hypertension, and irregular respirations. Okay. So this is the bradycardia, tachypnea, and hypertension. So this is the Cushing reflex. So these are all the signs of the raised intracranial pressure. So whenever you are in your own hospitals, whenever you see these things, so that means this patient is going to survive or die. So the mortality will be very, very high. So don't keep. Okay, we have to send it for ICU setup, multi-specialties, or in medical college, because the chances of survival, if the patient develops these things, is very, very, very low. So what are they? Deteriorating or reduced level of consciousness, deeply comatose, papilledema, poorly reacted pupils. So pupils are dilated and non-reacting or poorly reacting. Sixth nerve palsy, not eighth nerve. Eighth nerve is very common. Recovery is also very good. Sixth nerve, raised intracranial tension. So take care of the sixth nerve is dangerous. Decerebrate posturing, and then the Cushing's reflex. So the bradycardia, hypertension, and then varied respirations. So this is the very, very important. So the most disastrous complication of the increased intracranial pressure is the cerebral herniation. 1 to 8% of the cases. So these are the investigations. Resuscitate and stabilize the patient. Initial tests like the blood cultures, polymerase chain reactions, throat swabs. See, the blood cultures is also important because some of the meningitis is because of hematogenous spread. So that is the reason. So send the CSF for the culture and sensitivity, and also send the blood also. And the PCR is also very important. Okay. So the polymerase chain reactions. So the PCR of the different organisms. So that also will help you to detect the exact cause of this meningitis. And empirical antibiotics. So definitely have to start it maybe with your ceftriaxone plus vancomycin, or from ampicillin, or your other antibiotics. And then drowsy and the focal signs, possibly mass lesion, hydrocephalus, cerebral edema. So definitely they need MRI. So the CT scan, no mass lesion, hydrocephalus, or other contraindications for the LP, then the LP has to be done. So this is how you have to go for the lumbar puncture. So this is the L3 and the L4. So the different cells. It is a mandatory unless there are contraindications. Particularly if the patient is drowsy with the focal neurological signs of the seizures, obtain a CT to exclude a mass lesion such as a cerebral abscess before the LP because of the risk of the coning. Sometimes, no, when the fellow is present with a long duration of the symptoms, so there could be a brain abscess also. Brain abscess. See, brain abscess again mostly in the frontal lobes. If the abscess is, if the root of the infection is from the sinuses, maybe in the temporal lobe, brain abscess. If the root of the infection is from the middle ear or from the mastoids. So the mostly the two areas where you often see the brain abscesses are the frontal lobe and the temporal lobe. Frontal lobe because of the chronic sinusitis, and the temporal lobe because of the chronic otitis media or chronic mastoiditis. Some people may have the multiple abscesses. Multiple abscesses are also common in certain conditions because of the hematogenous spread. So in bacterial meningitis, the CSF is cloudy. It's a very turbid due to the presence of the many neutrophils. Immediately after the LP also we can say whether it's a bacterial meningitis or the Cox meningitis. The pressure will be very high and the CSF is turbid. Normal CSF is like your water unless it is a blood tap. Okay, so mostly it is the water that is the CSF, whereas if some turbidity is there, and definitely you can suspect the bacterial meningitis here. The protein content is significantly elevated, the glucose is reduced, gram films, gram cultures, gram stains is needed, and blood culture and sensitivity is also very much needed. As I told you that polymerase chain reactions, PCR techniques can be used on the blood and CSF to identify the bacterial DNA and useful in detecting the meningococcal infection and in typing the organisms. See the here. So the contrast enhanced CT, the right-sided frontoparietal ring enhancing lesion with perilesional edema. See on the first one, so you'll have a small. And the second picture, center one, is the contrast enhancement in the ventricular ependymal lining, suggestive of ventriculitis. So the ventriculitis, that's one complication of your meningitis. See the ventriculitis, a beautiful picture there. And the third one, last one, is a meningeal enhancement in the falx cerebri. So that is the green arrow. Okay. So the falx cerebri, ventriculitis, are in these lesions. So one has to be seen in all the meningitis population. If meningococcal or other bacterial meningitis suspected, the patient should be given a parenteral benzyl penicillin immediately. IV preferable to the IV. So always IV only. So don't think of the subcutaneous or oral or intramuscular. Always IV only. So it is mostly of your penicillin group. And nowadays we are not using the penicillin G, but definitely cephalosporins like your ceftriaxone. So contraindication is history of the penicillin anaphylaxis, where you can use the chloramphenicol. A prompt admission to the hospital is very much needed in all the meningitis population. Don't treat it as outpatient. Empirical therapy before the cause of the meningitis is known. Antibiotic regimen may be modified after the CSF examination depending on the infective organisms. Adjuvantive corticosteroid therapy is very, very useful. I told you the why should you give the corticosteroid therapy. So what will happen if you give the antibiotics? These antibiotics will kill the bacteria. So after the big bacterial death, so they degrade the toxins. So these toxins will act to get more and more inflammatory cytokines, like your tumor necrosis factor, interleukins, etc. So once you give the steroid before your antibiotics, so the toxin released from the bacteria will be reduced, and the toxins producing your inflammatory cytokines will also be reduced, so that the granulation will be reduced and the recovery will be the good. Am I clear? So if time permits, so first give the steroid and wait for about 10 to 15 minutes, then give the antibiotics. Otherwise, you can give the steroid and the antibiotic at a time. But don't give the steroid after 1 hour or 2 hours or 3 hours of the antibiotics, because you are killing the bacteria and you are making the bacterial toxins, more and more bacterial toxins, and these toxins will release more and more cytokines, inflammatory cytokines, and they damage and they cause a lot of the complications. So that is the take home point. So the take home message here is give the steroid therapy prior to your antibiotic therapy. So the treatment of the bacterial meningitis of unknown cause. So the patient with the typical meningococcal rash, so you think that it could be because of the meningococcal meningitis, give the benzyl penicillin, penicillin G, say 2.4 grams, not OD or the BD. Once you give this is the crystalline penicillin. Okay, so you have to give the 6 hourly only. Adults aged 18 to 50 years without the typical meningococcal rash. So you can give the ceftriaxone or the ceftoxime, 2 grams IV, 12th hourly, or maybe the 8th hourly also. Okay. So the typical rash, mostly of the meningococcal meningitis, where you can give the crystalline penicillin CP, we consider the CP, it's a 2.4 grams, 6th hourly, or without the rash, you can give the ceftriaxone 12th hourly. If the patient is having the resistance to the ceftriaxone or the penicillins, then you can go for the chloramphenicol or the ampicillin or vancomycin. Patients in whom penicillin resistant pneumococcal infection is suspected. So here the vancomycin, 1 gram IV 12th hourly, or the rifampicin 600 milligrams IV 12th hourly. So we don't use the rifampicin IV here. So we use the vancomycin very frequently in the meningitis. So our powerful drugs are the benzyl, your crystalline penicillin, and then ceftriaxone, then the vancomycin. Adults aged 50 years and those in whom listeria infection is suspected, example the brainstem signs or immunosuppression, diabetics or alcoholics. So as for 2, but add the ampicillin. As for 2 means your ceftriaxone or the vancomycin, then you add ampicillin also. So listeria is very sensitive to ampicillin. Cotrimoxazole is also not available in India in IV form. So we don't use the cotrimoxazole and we don't use the rifampicin IV. So we use the vancomycin, then we use the ampicillin also, provided if you think of listeria or the CSF culture intensity shows the listeria, then we the ampicillin we add. Patients with a clear history of anaphylaxis to the beta-lactam antibiotics. Then I told you chloramphenicol is the answer here. So chloramphenicol alone is not sufficient, then you add vancomycin. In the same way, ceftriaxone alone is not sufficient, you add vancomycin. So chloramphenicol plus vancomycin. So this is the empirical antibiotic therapy in the bacterial meningitis. See the children less than 3 months, we are not interested. 3 to 18 years, not interested. 18 to 50 years and above 50 years. So see the third group. The common pathogens are Streptococcus pneumoniae, Neisseria meningitis, that is a meningococcal meningitis, and Listeria. Here the empirical therapy, vancomycin plus third generation cephalosporin. Third generation cephalosporin means your ceftriaxone. Okay. Above 50 years, Listeria and gram-negative bacilli. Here again the vancomycin plus ceftriaxone plus ampicillin. So in elderly individuals, vanco plus ceftriaxone plus ampicillin. Whereas 18 to 50 years of the age group, then we can use only vancomycin plus ceftriaxone. Pathogen-specific antibiotic therapy for bacterial meningitis in adults. See the Streptococcus pneumoniae, antimicrobial ceftriaxone or ceftoxime plus vancomycin. Dosage 4 grams per day, duration 10 to 14 days. So this is very important. So no meningitis case should be discharged without giving a minimum period of 7 days IV therapy. So 7 days in some cases, 14 days in some cases, 21 days in some cases, and some cases maybe a 28 days or 1 month also. So somewhere between 1 week to 3 weeks is the minimum antibiotic therapy one should be given in meningitis individuals. If it happens to be Streptococcus pneumoniae, which is the most common cause, you are supposed to give it for 2 weeks, 14 days. Okay. If it is a meningococcal meningitis with some rash, even 7 days is sufficient. So Haemophilus influenza, 7 days. Again Listeria, especially in the neonates and in the elderly individuals, and again you have to give for the 21 days. So 3 weeks here in the Listeria. Pseudomonas aeruginosa. So that is also very common, where you have to use for the 21 days. Okay. Here the ceftazidime or the meropenem plus vancomycin, plus linezolid. See, this is the most likely pathogen depending on the primary source of infection in the brain abscess. So, middle ear, Streptococcus, bacteroids, E. coli, Proteus, Streptococcus pneumoniae, and often mixed in organisms. So, that is from the middle ear. Sinuses, there is Streptococcus pneumoniae or Streptococcus miliarii. So, that is your pansinusitis or frontal lobe brain abscesses. Hematogenous, from the pyelonephritis, from the urinary tract infections, from cholecystitis, from enteritis, or from your hepatitis, etc. So it is hematogenous spread, various pathogens depending on the source. Mostly Staph aureus, very, very dangerous. Okay, so Staph aureus or Streptococcus viridans. Head trauma is a very common nowadays. Staph aureus again and gram-negative bacilli. Lung abscess, Streptococcus miliarii and Klebsiella pneumoniae. Immunocompromised patients, nocardia, aspergillus, candida, and other opportunistic pathogens. So this is depending on the site of the origin. So we have the different organisms. So if you know this, you can choose the antibiotics of your choice. So for example, if you are thinking that it's from because of the listeria and whatever the antibiotics you use without the ampicillin, the recovery will be very, very less. And if you think that it is because of the Staph aureus, so where you have to use very aggressively for a very longer period also. Suppose if it is because of the pneumococcal pneumonia, even a 7 days therapy is also sufficient. And if you think that the rash and the meningococcal meningitis, definitely have to use for 14 days. So these are the very important clues to know before the culture and sensitivity report is in your hand to which organism and which antibiotics. The same thing here. In meningococcal disease, mortality is doubled if the patient presents with features of septicemia rather than the meningitis. So when the patient presents with the sepsis or septic shock, also meningitis, so chances of recovery are very, very low. Patients likely to require intensive care facilities and expertise include those with the cardiac, respiratory or renal involvement and those with the CNS depression reducing the air. So multi-organ failure, very, very common. Chronic diabetics, elderly, so the blood sugar will be 300, creatinine will be 1.6, SGPT will be 200, SGOT will be 160, and urine output will be 1200 or 1800 or maybe 900 per day. So definitely a multi-organ failure. And again, here the recovery will be doubtful. Early endotracheal intubation and mechanical ventilation protect the airway, may prevent the development of the acute respiratory distress syndrome. Adverse prognostic features, shock, rapidly developing rash, hemorrhagic diathesis, multi-system failure, and age more than 60 or 70 or 80 depending on the immunity. So increase in mortality and the poor outcome, a decrease in level of consciousness on admission, onset of seizures within the 24 hours of admission, signs of increase in intracranial pressure, young age, that is infancy, and the age, elderly, the presence of comorbid conditions, including the shock, a need for the mechanical ventilation at the time of admission, delay in the initiation of the treatment. So all the 5 is the patient's problems, but our problem is delay in the initiation of the treatment. That should not delay. You should not ask your junior to do all these things. So you should be there, and the treatment must be aggressively started immediately. So that is very important. You have to take the to do the LP or not to do, or to send it for the MRI or the CT or not, and then to start the which antibiotics. So these are the very, very important for all of you. So decrease the CSF glucose concentrations, markedly increase CSF protein estimations. That also tells you a bad prognostic signs. Prevention, household and other close contacts of the patient's meningococcal meningitis infections, especially children, they should be given a 2 doses of the oral ampicillin. So there is a chemoprophylaxis. So all the contacts are the family members or the friends. Here you can use the 2 drugs. One is the rifampicin, you can give for the 2 days, or you can use the ciprofloxacillin, 500 milligrams BD for just 1 day. So you can give the ciprofloxacillin, 500 milligrams BD for 1 day, or rifampicin 600 milligrams OD for 2 days. If not treated with the ceftriaxone, the index case should be given similar treatment to clear the infection from the nasopharynx before the hospital discharge. Vaccines, already told you 3 vaccines: H influenza vaccine, meningococcal vaccine, and then the pneumococcal vaccine. Adjuvant therapy, already told you the dexamethasone. Steroid is the adjuvant therapy. IV administration, 15 to 20 minutes before the first dose of the antibacterial agent. Why I told you? Same dose repeated every 6 hours for 4 days. So don't give only single dose. So you need to give this dexamethasone every 6 hourly for about 4 days. Emergency treatment include elevation of the patient's head in rise in intracranial pressure. Elevation of the patient's head is important. And intubation and hyperventilation, mannitol. Here the role of the mannitol. If you think that it is a rise in intracranial tension, give mannitol. Otherwise, role of mannitol is 0. See here, big abscess. Which lobe? Frontal lobe. So what is the site? Most commonly from? Good. Sinusitis, nasal sinusitis. It's a big abscess, thick walled abscess. See what is the, here the abscess site? Parietal lobe. Okay. What could be the site of origin? So yes. So the DD of the ring enhancing CT lesions. Large lesions, more than the 2 centimeters, more than the 20 millimeters. Brain abscess, already showed you 2 pictures. Brain tumors, maybe gliomas or secondaries. Tuberculous abscess, fungal abscess. So these 4, you will have a large lesion of more than 2 centimeters. So abscess, brain abscess, tumors, tuberculous abscess, and then the fungal abscess. Small lesions, that is less than the 20 mm, less than the 2 centimeters, commoner NCC, neurocystic cirrhosis granuloma, and then the tuberculomas. Sometimes in a old infarct, focal encephalitis, sarcoidosis, microabscess, vasculitis. In immunocompromised patients, HIV positive, toxoplasmosis, lymphomas, fungal granulomas. These are the very important. So you remember the first 4 conditions where the abscess, the size will be more than 2 centimeters. So brain abscess, brain tumors, tuberculous abscess, and then fungal abscess. So what are the indications for the CT scan of the head? In general, any head injury or skull fractures, stroke, not to diagnose the ischemic stroke, but to exclude the hemorrhagic stroke, we need the CT scan. But in ischemic stroke, you have to wait for about 6 to 8 hours. So immediately get the CT scan to rule out the hemorrhagic stroke. Suspected hydrocephalus, suspected intracranial hematoma, evaluation of headaches, diseases or malformations of the skull, the anatomical abnormalities, initial evaluation for space occupying lesions, seizures, unexplained change in the mental status. So these are the indications for your CT scan. What are the contraindications? CT has no absolute contraindications. Caution is indicated in the pregnant women, particularly during the first trimester, to avoid the fetal abnormalities. Repeated X-ray exposure may increase the patient's risk for the cancer. What are the indications for MRI? Vascular, ischemic and hemorrhagic stroke, AV malformations, aneurysms, venous thrombosis. So the AVM and aneurysms are common for your hemorrhagic strokes. So that is the indication for your MRI to rule out these things. And abscesses, cerebritis, encephalitis, meningitis. Again, brain MRI will give you a good picture about your frontal lobe, parietal lobe, temporal lobe, cerebellar lobe, etc. Inflammatory and demyelinating lesions like multiple sclerosis, sarcoidosis, etc. Tumors may be the primary or the secondaries. Trauma may be epidural hematoma, subdural hematoma, or contusions, hydrocephalus. So all these things can be seen very effectively in your brain MRI. There are certain contraindications when the fellow is not cooperative, when the fellow is moving. So definitely we need the CT, not the MRI. Implanted devices and other metallic devices. So the MRI is contraindicated, like pacemakers or electronic devices, aneurysm clips, okay, cochlear implants or artificial heart valves. intraocular metallic foreign bodies. So these are the conditions where MR is contraindicated. So with this, I stop. To change your life, you need to change your priorities. Okay. So this is very, very important to become a good citizens, good physicians, or good super specialists in the coming years. So know your priorities. That's very, very important. Thank you very much for your patient hearing.